All right. So good day, everyone, and welcome to the the digital mental health table, coping with trauma in times of war and beyond, hosted by the German-Israeli Health Forum for Artificial Intelligence. It's my pleasure to welcome you to today's online roundtable, together with my colleagues, Lea Ledwon and Genoveva Bavarios from Germany and Israel. And this roundtable is hosted by the European Leadership Network following the brutal attacks by Hamas on Israel on October 7th. And in the aftermath of it, the entire country is suffering under this traumatic event and the ongoing war against Hamas. And while at the same time these days we celebrate Hanukkah all around the world, a festival of light, we hope to provide some light in times of darkness with the German solidarity for Israel, but also with some support from today's roundtable. As we know, the impact of Israel's healthcare system, particularly in the realm of mental health, is profound. And ELNET has been fostering connections between both healthcare ecosystems through this forum already since 2021, with a goal of mutual support and learning from each other. And therefore, this event on digital mental health aims to assess both the immediate and future needs of Israel in the context of expected pathologies and available therapies, and also taking into account the availability of medical staff. The focus will be on sharing German expertise, experiences, and approaches, specifically within the mental health ecosystem, digital mental health applications, study results, and relevant use cases. And additionally, the objective is to explore ways in which German health experts and institutions can offer practical support to their Israeli counterparts and friends during these critical times. ELNET already started a while ago, last summer, with a digital health delegation and a digital mental health day in summer 2022 with this topic. And since then, we have published, we have done roundtables, and we will continue to do more to exchange ideas and to bring together the best experts that we have also here today on this topic from both countries. For today's roundtable, it's our pleasure to welcome Professor Ran Balica, who will give an outlook and an impulse on internet-based treatments for trauma-related disorders. And I can only invite all of you from the very beginning to write down questions and topics you would like to discuss later in the workshop. And please keep in mind, this session is on the record, so that means it will also be recorded and available afterwards. So I hope I did not forget anything at the very beginning. And without further ado, dear Ran, the floor is yours.
Thank you very much, Carsten. Leah, it's really a pleasure to have the opportunity to speak with you guys today. And I would like to begin by expressing our gratitude, I think, as a nation, to the people of Germany for their outstanding support of Israel in its darkest times. This is well felt by every individual as well as decision maker in this country. And so my heartfelt thank you to all of you involved in this. So with no further ado, what I would like to do is I got about 10 minutes just to kind of give an overview to jumpstart a discussion that will take place soon. And my name is Ran. I'm a physician by training. I'm the Chief Innovation Officer for Israel's largest healthcare system called Clalit. And in that capacity, I would mention that Clalit is also the direct insurer and provider of care for about 70% of the people that were most badly influenced by the current event. And therefore, some of the lessons learned from what we've already seen might be worthwhile sharing. So this 10-minute overview is going to look at 4 things. What's so unique about the event that we're talking about? What was the baseline state of the mental health care system in Israel when all of this happened? What were some of the immediate response and mitigation steps that were taken? And finally, a few ideas about the way forward. So let's begin. So I think that there are quite a few elements that make this specific event quite unique when we look and compare it to other events. Let's start with just in terms of numbers. So we're talking about in terms of casualties within one day, we're talking about a rate that is about 13 times that of 9/11. We're talking about basically 1,300, so that's about 13 per million. Everybody can do the calculation for their own country and figure out what that means in sheer numbers. The second thing that makes this unique is the intensity. If you look at Israel, Israel already has, 1 degree of separation between everybody. It's a small country. So, 9/11, most of the people got up in the morning and didn't know anybody that was directly inflicted by the event. But in Israel, everybody knows someone that has been inflicted. The third point with the strong mental health impact of this unique event was the individualized barbarity, the fact that you had the face-to-face horrendous acts being done and then taken on video and then shared widely would have a tremendous mental health impact, both on the victims, but also on everybody who's been involved in caring for them and of course, the first responders. The fourth component that makes this unique is this has invaded people's home. So unlike events that happen far away, the feeling that this might crawl into your house, to your bedroom, to your kid's room, wherever you are, is something that has a tremendous mental health impact. And that makes this event very, very unique. The fifth component or issue is the fact that there were hostages, and hostages, children, women, elderly, mentally ill, taken, and that also is very detrimental in terms of the overall impact. Rockets that reach every part of the country, and therefore, even if you were not directly involved in the October 7 events, you are inflicted ever since that point in time with physical danger. And finally, the continuous risk. This is not something that happened and then stopped like 9/11. This is a continuous, imminent risk. Now, when we talk about perceived risk, some of you who know risk perception theory, you know that the thing that frighten us are not the things that kill us. Generally speaking, we tend to be afraid of things depending not only on the actual measured risk, but based on other things. And one of the persons who had the kind of framework for this was Peter Sandman. And he said that the way you perceive risk is based on the risk itself and the dread. He called it hazard and outrage, doesn't matter. But basically what he said that some components of risk make them more fearful associated and some make them less fear associated. And so if you take things like involuntary events, things that one has no control of, things that there's no benefit to the individual, that are man-made, that are exotic and traumatic and catastrophic, and those that affect children, these are the things that make people more afraid than the actual risk. And if you think about October 10, all of those boxes are checked. So the risk for the individual in Israel, as it perceived, is augmented dramatically by some of these risk perception modifiers. So this is the event. Now, where did it meet the Israeli healthcare system? In a very unfortunate place. We had a reform in 1995 where in 2005, I'm sorry, there's a typo here. In 2015, where we have moved the responsibility on mental health to the HMOs. So in 2015, a lot of the responsibility moved to the HMOs, but the assessment of what the HMOs would need and what would be the needs of the population were dramatically underestimated. And this caused a high demand and low yield that pushed a lot of people to the private care setting, a lot of provider shortage and in the public service, long waiting times that made a lot of people go through preventable deterioration because they had nowhere to go with their issues. The system itself was unstructured and opaque, which means there was little monitoring. You didn't know even things like waiting times, because mental health data is considered privileged and very much well kept. It also worked on the other way around, where there was little monitoring like you have in physical health. So this whole thing was really unmanaged in many instances, with a lot of one-size-fits-all approaches. So all of this, I think, this baseline tells you that we had a dysfunctioning mental health system to begin with, before the October 7. And the one thing that worked really nicely, I think, are what they've had, which is local resilience centers in different areas, especially in frontline areas like around Gaza, where local communities created resilience centers that really helped the people build resilience towards the continuous threat that they've had. So war was actually acute on chronic, a chronic dysfunction that met acute needs and was truly problematic. Now, in terms of the response, the first thing that we must understand that this has a rippling effect. So there were some challenges are increasing as you are closer to ground zero. So the biggest needs are among those who have survived the massacre themselves. Then there's a group of first responders that were there in the area of atrocities and saw things that would make any person not sleep probably for months. Then there's people who have since lost their home, had to be evacuated. They're in hotels around the country or in some kind and so that is a great. And finally, there's the subgroup of the hostages coming back that nobody knows really how to deal with this type. There's no historical precedent. So we wouldn't expect, based on other people's experience, that 10 to 15% would have PTSD and 7% would have depression. But that's the lessons from 9/11. But to which circle is that true for? Only for the survivors? Also for the first responders? Also for all of the evacuated? Also for everybody who has witnessed a launching of rockets near their home? We don't know what to expect. But the data suggests that if you do an immediate response, you can reduce by 30% some of the detrimental impact. So what happened in practice in terms of was really all hands on deck, amazing volunteering, and a lot of people came in to those hotels, to Eilat, to the places where the evacuees came, and really tried to do everything they could in order to bring them some support, structured or less structured. Mass recruitment, so HMOs began recruiting additional manpower, but there isn't enough providers that are willing to work in the public service to meet all the demand. The resilience centers continue their blessed work in the new places where the people have been put in hotels, etc. And we opened pop-up clinics in the refuge cities. So in Eilat and in the Dead Sea, where a lot of evacuees came in, we opened unique, out-of-the-blue clinics, only dealing with mental health and trying to provide them with services. And finally, we opened a dedicated call center and a lot of online services to provide to these people. My last slide is to jumpstart this discussion is looking forward. And looking forward, basically, the most important thing is risk stratification, is understanding that we need, there are some low maintenance tools that are less human effort strenuous. And that's the basis of the pyramid. And as you go up, this is becoming more and more strenuous for the providers. And so what we are looking to do now is a whole system redesign. We are going to rebuild our mental health system as the challenge is upon us. We have created unified triage centers that work totally online. So with phones, usually, that are able to make triage, and then they go through risk stratification by questionnaires and by other modalities. We will stratify the entire population according to the level of needs, and then direct the people according to the need to the level of care that is most appropriate to them. So risk is stratified, and then you can stratify care accordingly. Finally, we are creating a whole new caregiver strata, a whole new type of caregivers called resilience supporters or coaches. You can see them here in the red rectangle between the GPs and self-help. These are people who, following the English model, will go through several weeks of training, and after which they will be able to provide specific help to people according to the GP guidance. So the GPs will guide people to those new providers in order to increase the amount of care that we can give that is dealt with. And finally, we're in a process of creating and introducing a lot of digital innovation into our system. And what we've done about a month ago was put out a call for innovation at Clalit. So this call asked for all of the ecosystem, locally and globally, to come in and bring the best and brightest innovations so we can assess which ones of those can help us with what we need in terms of risk stratification, staff assignment, mental health clinic management, self-diagnosis and self-help tools that actually work, because there's a lot of things out there, very few that actually have any evidence that they work, training tools, and finally anything else. And we are now in the process of canvassing through those and choosing the best ones so we can then put them into our system and start really rebuilding our mental health care system in the modern, digital, data-driven, evidence-driven system that will be able to mitigate all of those huge challenges that we are now facing. And we're looking forward to learn from your experience over there in order to help us in this journey. Thank you so much.
Toda rabba, vielen Dank. Thank you so much, Ran, for this very important and insightful overview. And I mean, all of us are still definitely under shock. And even though we know the numbers and have discussed the numbers in depth, every time seeing this and the magnitude of these barbarous attacks still makes me personally speechless. So thank you again for giving us an overview on the medical and the mental dimension of this issue. Because you just had this last slide as a call for innovation on, and I saw the deadline already expired. So can you tell us already a bit more what kind of innovative solutions have been submitted, or if there are now people maybe also here on this roundtable today, or will review the video afterwards, is there still an opportunity to apply if someone else has an innovative idea how to help?
So absolutely, you can still apply, and this is not a one-off thing. This will be a continuous process that will take many months ongoingly, and things will come in gradually as we assess the evidence and the needs and learn more about what is offered. I would also mention, if you want to, we just about an hour ago, I went with a team on some of the highest ranking submissions. So I can tell you that there are many different types of ideas there. A few examples. There are the various tools that allow you to have an early diagnosis based on anything from voice patterns to behavioral patterns to many other things that make you understand that you can potentially identify people passively on a potential threshold for a mental illness. And then your question is, do I need an additional influx of potential cases, and in which cases do I need them or not? Then you have a lot of digital clinic management solutions. Some of them are to specific parts of the management, some of them are overarching and provide a whole suite of solutions for caring for remotely on psychiatry. Some of these are more geared towards self-help, various types of self-help. VR glasses that provide you all kinds of things that you can do. So this is another group of solutions. There's a group of solutions of training. How do you train healthcare professionals in various components of care provision? There are bots that allow self-assessment of people and going through the assessment. I think you got the drift.
Wow, amazing. And be assured if there's anything we can do to help to extend this call for action, just please let us know, and we will be there with our teams in Germany and in Israel. Right. Before I hand over to Yael Ophir, the Executive Director from Health IL, are there any further questions directly to Ran? This would be your opportunity. Okay, no need to be shy. Just use a raise your hand button, or just unmute yourself if there's anything you would like to say, to contribute, to ask. Okay, if not, we will have time also later on in the discussion. And I'm trying to find my dear co-moderator. Maybe Leah, you could already give the rights to Yael and welcome her on stage to take over from here for the digital mental health best practices from Germany.
Yael, your co-host now. You're very welcome to join.
Great. Hi. Can you see and hear me? So thank you everyone for joining, and ELNET as our wonderful partners already, I think for almost 2 years already. So thank you so much for that, and thank you, Ran, for really a very nice throughput of explanation of how really mental health have been affected and how you deal with it. And we're very happy to also be part of this with you, with the HMOs and with the health organizations in Israel. I'm the executive director of GIHF-AI. We are supporting the Israeli health system in transformation and innovation. And I think that the first engagement and the first act that we've done really just a day after October 7th was to put the mental health issue on, we identified it like a lot of other people and have decided to be the beacon of looking at not as immediate response, where most health organizations would definitely deal with, really immediate responses, but try to bring more of the, I would say, short, medium term of how we can handle and leverage technology in the mental health area. By that, we actually brought 60 of our innovation managers from the health organizations and identify with them what are the key challenges, as Ran, mentioned. And we started to map different technologies in Israel, but also abroad. The first wave was actually to map the Israeli technologies, and about 45 of them that are relevant for the different challenges of mental health, the immediate ones and the long-term ones. And then since we are working and with ELNET and other global partners, we actually decided to reach out to the global partners to hear from them how they deal with mental health, both in the health system infrastructure and also in tech. We got dozens of responses, which is very heartwarming and not that trivial in the landscape of today. And we were able to increase, for instance, the mental health mapping from 45 to even 60 relevant technologies that are not only from Israel. And we are very happy for the collaboration. We've done a lot of other things, but I think the main thing here is that the healthcare ecosystem really looking forward in these times also to learn from others. And we think it's not something that really only used in times of crisis, but actually needs to be pursued on and on. We are very happy to have this event together. And when we reached out to Carson, Leah, and Gino, and all the others, we really were happy to do that. The stage is really to learn from what has been done also in Germany, and we believe that according to all the progress that's done together in the past 2 years, also with the Ministry of Health in Israel and in Germany, this is the right thing to do. So just before we start, and we'll showcase the different impulses by the guests that joined us, I wanted really to mention that we are hosting, as part of actually rebuilding healthcare reality in Israel, we're decided to have our annual event, which is the 6th time, to keep it and have it on February 6th, even though it's maybe not that trivial, but we need to look at things to learn from what happened, but also to look at the future and the resilience of the entire field. And we are more than happy to invite participants also from abroad. I know that Leah and everyone there said that they would be really happy to come and learn. We'll do it in a safe place, obviously. And we are very happy to bring, even though it's will not be only about global partnerships, but it's going to be about lessons learned and how we can collaborate together, and now more than ever. So you're all invited. Leah, would you like to, you're my co-host, right? So
I'm actually your co-host at the workshop, which follows.
Okay.
Let's start with the impulses.
Sure.
I think Professor Maria Böttcher is already waiting.
Perfect. So we can start with the first one: internet-based treatment services for trauma-related disorders in different populations.
All right, I prepared only some slides. And I wanted to just to give you a really short overview about what I mean, or what you can understand when you read internet-based treatments. And I will start with a meta-analysis concerning the efficacy of internet-based intervention when it comes to post-traumatic stress disorder. And you can see that it is in favor of internet-based CBT when comparing to wait lists. So then we can assume that if we offer internet-based treatment, especially for PTSD, that it will be effective in reducing these symptoms. And when I talk about internet-based interventions, there are like a bunch of different interventions. You can find papers on the internet. And so what I was talking about is when you have a combination of using the internet as a communication tool and as a source of information. So it is different concerning like an online-based self-guided interventions, and it is different when you talk about video-based interventions, when you have like an synchronous chat and talk. So what I'm talking about is, and what I will present with two examples, are therapist-guided interventions that you have like an asynchronous communication and using it as I said, a source of information and a communication with trained and specialized therapists. So now it doesn't work. So to get an idea, really brief idea of what is this internet-based therapist-guided intervention, it's mainly manualized, that you have like a manual which you have to stick to. It's text-based very often. That means it's a written-based intervention where you can write each other as like back in time when you have letters writing to each other in a secure platform, which is really highly secured. And normally it will take 8 weeks and uses techniques of psychoeducation, cognitive restructuring, and trauma exposure. That means you have techniques which are actually evidence-based, effective also in face-to-face treatment, and which you take to the internet and then also contributed to the internet-based setting. And I will present two totally different internet interventions. One I did as the head of a research department here in Berlin for war and torture victims. It's called Ilaj Nafsi. It's an internet-based psychotherapy for people living in the MENA region. We have it now for over 10 years. We have about 1,300 new registrations per month. And looking at the participants, we have mainly highly educated, younger female persons who are single or married and living in the city. So this is like a profile of persons mainly living in Saudi Arabia, but also in Iraq or in Egypt, with different ideas of why they come to us and want to do the internet-based treatment. So if you are interested in, we have like a bunch of articles already published saying that this internet-based intervention is highly effective in reducing of PTSD symptoms in these kind of population. And a totally different population, we have a collaboration or had a collaboration with the Mount Sinai Hospital in New York. And we also adapted the internet-based treatment for PTSD for first responders. That means it's a difference between the civilian traumatization or civilians we have in Ilaj Nafsi, and here the first responders, mainly police officers and firefighters. And so you can see that the participants are here middle-aged, employed as firefighters or police officers. We have like 50-50 male and female, and they're mostly married and partnered. And also here, we reached out to them, offered online-based treatment for PTSD. And because there's so limited time, I only want to conclude that mainly when we talk about internet-based treatment, we address young female and high educated persons. This is also for other interventions. But if you address the special needs for the specific audience, you can also address different persons. We know that there is evidence for the efficacy of internet-based treatments, but we have a lot of challenges. So we need a secure platform where we can offer that. That means we have to just also have some money or a lot of money to build these secure platforms. We have to have trained therapists and counselors, which are supervised during the whole time. And then it is possible to offer and conduct these internet-based treatments. And that's it for now.
Thank you so much, Maria. Just to make sure, so we are open for questions, or are we doing it later?
No, I think I wrote down in the chat that if people have very urgent questions they want us to get answered now, then that's fine. And if it's a bit more complicated questions or questions for the whole speaker audience, then we'll do that in the workshop.
Okay, so if anyone has questions, I think I have a quick one just to make sure. Do you say it's more effective for younger people, or just because you tested it? I'm just referring it because there's a lot of also issues addressing the elderly population actually via internet, which is also highly effective these times because they are, some of them at least, using more internet.
No, it's also highly effective. We also did it with older persons, like above 70, and it was also effective, but mainly if you spread it, like in general, you receive more participants saying, I want to have a psychotherapy, and they're mainly younger and female. So if you just spread it in general, then you mainly have this audience, but if you address it specifically, it's also effective for older persons.
Okay, perfect. Lars?
Well, thank you. I was just, it's quite interesting that you mentioned the demographic, in particular the range of age, because that is something which is quite interesting that we're seeing when it comes to reimbursement of certain digital applications in Germany. We're actually seeing that the range, and we will have more details and better data from next year onwards, but we're seeing that it's not necessarily always a phenomenon that resonates with a younger crowd. It's rather in like a middle range between, or in rather in a demographic between 50 and 65. So it pretty much depends on the type of the application and who's the targeted group. But we're seeing, and that's what we can see from the data. And again, it will be better in next if we talk in like 1 or 2 weeks. But it's also something that can resonate with an older demographic. So it's not necessarily limited, and it's rather related to the fact how you build an application and which design and usability you apply in order to get people to use it.
Maybe Lars, you can shortly introduce yourself, please. Thank you so much for joining, and also your work on the DIGA, the digital health applications, because I think this is a very important topic also for the workshop later on.
Yeah, of course. Thank you. I didn't want to take too much space and room in the discussion, which is certainly interesting. I'm deputy head of the unit here in the Ministry of Health in Germany that is involved in both in telemedicine, the delivery of telemedicine, and we're trying to advance telemedicine in the use, but also digital health applications, notably DIGA medical devices, low-risk medical devices, but also in future, Parliament will probably give its okay tomorrow for high-risk medical devices that can be used for treatment purposes, a lot of range of treatment purposes, in particular mental health. We are doing quite good here, I guess, and again, it's something which is quite interesting to us, because what probably, just to give you an idea what is going on at the moment, why we actually address Parliament is because first of all we're seeing that structured and structured and like foreseeable and quality-driven, evidence-driven integration of digital health technologies in the delivery of care is something that is helpful, that can benefit the system. We started low key with low-risk medical devices. We've got some learnings in terms of how these applications can be introduced in a more effective manner. At the moment, we focused on standalone applications. The idea of advancing blended care approaches is something which is next to traditional remote intervention via telemedicine, something that is important, that is working, and we're seeing an uptake there. And that is something that we're advancing, that we're quite interested in, and I hope to contribute our expertise we gained in the last years, and we are hopefully gaining in the next weeks and months when Parliament okays the next step in the legislation, I guess.
Thank you so much, Lars. Yael, I'll pass back on to you, and then
Yeah, so I wanted to invite Malek to present shortly digital mental health solutions, experiences from international projects. So here you go.
Thank you, first of all, for inviting me and giving me the opportunity. And you invited me, the topic was best practice, and I often have difficulties for best practice. Maybe it's a good practice, and I would like to share some experiences which we had in international collaborations. And I think one thing is very, very important. Even the darkest events at the end might have a positive impact. And the positive impact is that nations together, partners together, develop something which is in the best case better than the situation which had been before. And if you have a look at this pictures, so we had obviously this very, very disruptive event, and as Ran already said, so the idea is that we do not come back to the normal, but rather we have a better system at the end. And you do see here the aim, I think, with which we all are agreeing of. So we would like to have a resilient health system which can prevent, prepare, detect, adapt, and respond and recover to public health threats. And I think that had been elaborated quite well before. So if you allow me to take a bird's eye view, there are a number of challenges with which we have in the field of health and mental health too. So conflict settings and it is currently the case, but it's also things like public trust, access to medicine. So how many available capacities do we have, and how do we properly use new technologies? And would like to give you a couple of insights and things which I think are important. Number one is, if we develop new interventions, be it in an analog way or digital way, it is increasingly important to take into consideration those people for whom we are using and for whom we are developing it. So we need to go away from this way where we inform our patients what things are being done, or tokenism, but we, in the best case, we should quickly and in a meaningful way co-design and co-produce the interventions for our patients and beneficiaries. The second thing is that usually in such situations, we have difficulties in providing care to many people. So we need to develop, in order to avoid health disparities, things and interventions which are low threshold. And workshops like the one which is mentioned here is one example. The third thing is, and Ran already mentioned this, is that we cannot continue in a one size fits all solution approach. So we need to stratify. We need to develop step and collaborative care models. Is an example which we did here in Germany. So we initially tested our patients with respect to stress symptoms, and according to the level of stress, we did what usually people in medicine do not do. We did nothing. Yeah, so you just had a watchful waiting condition. Level 2 were non-expert intervention, a smartphone-based intervention which we developed, or a peer-to-peer intervention. Level 3 were group therapies, and only those who were severely affected received face-to-face psychological or psychiatric interventions. And what we have seen there is are two results. Number one, it was effective with respect to reduction of stress symptoms. And number two, it was highly cost effective. So I think this is a very, very important thing which we learned out of this case. The other thing is that in the last years, we co-developed together with colleagues in Ukraine after the war started in Ukraine, a couple of things. So we had a project called Solomia, where we supported more than 26 hospitals. And we did together jointly develop capacity building, an e-learning platform, which is avatar-based, where we delivered more than 2,000 training units in 12 programs, including staff care, psychological first aid, psychological trauma, resilience in children. And we co-developed a digital infrastructure and a chatbot which had been developed, which is being used by more than 100,000 users, an app, first stress management, others will follow, and a telemedicine network where we jointly discuss difficult cases. And one readout was beyond the part that we immediately support was that teams were built, Ukrainian-German teams, which are currently underway and providing things worldwide, solutions worldwide. So there's an economic component beside the hospital and medical component too. So the chatbot, I will skip that so we can discuss this later, is currently, by the way, being translated already to Hebrew because this postdoc who is doing this has the capacity to do so. The education of health worker is a part in our e-learning platform. Staff care, burnout prevention is one part. It is in hybrid formats, which we are delivering that. And this just should give you an overview of all the interventions which we developed in this 2-year collaboration, targeting patients, but also caregiver with digital online courses and in-person interventions. And for the next year, we would like to take all this to have a rather integrated digital care thing. And I think this is something which we can together discuss and can be translated and transferred and maybe used. And a couple of advantages of digital transformation, I will skip that. Importantly, the health force we need to take into consideration, medical products, health delivery, and the governance which needs to be involved. And what I said initially, and I would really like to stress this point, is that transformation usually happen in 2 ways. Number one, by design, and this often is not very, very effective, but in that case, when we really are in challenging times like we are currently, transformation happens faster. And you heard the plans and what is already happening in Clalit, and I think this is a perfect example for this approach. And having said that, I would like to thank you for your attention. I'm happy to take questions.
Thank you, Malek. Super interesting. Feel free to ask questions here. I have you've been doing a lot. So I was wondering if you can say maybe in a few tips of what was highly effective in that manner from your perspective.
Of course. So this is from the key point, and then usually if you take all the digital interventions, 90% of them are not evidence-based. Yeah, so we are currently underway in elaborating it and evaluating it and generating evidence. So the one thing where we really have now the good evidence is the stepped and collaborative care model. So it worked, it was effective, cost effective and clinically effective. All the other interventions which we're developing are currently under investigation in the pilot phases, differently large. We have seen the lowest level of evidence, but I think this is in such time the way how it goes. Importantly is that you do not forget to collect the data which you need to evaluate the evidence.
Perfect. It's a great start. So any other questions here?
Let's maybe, if it's not that urgent, maybe let's do the next impulse and then we can collect the questions and really talk about them in the workshop. I think then we can dig a little deeper. That's okay.
Yes, sure. So the next one is, it's not in the agenda.
It's Mariana about social.
So yeah, so the topic is integration of social workers into therapeutic approaches for mental health. And Marianne.
Thank you so much inviting me. I have to say first that I'm not a social worker. I'm a child and youth psychiatrist working in a big clinic in the southwest of Germany for many years. And of course, I'm used to work together with a lot of other professions, especially with social workers, because child and youth psychiatry, especially when you have to cope very, very severe disturbances and traumatic disorders, you have to work together in a network. But I will try to say my experiences or our experiences in Germany with social work. It's most of the broad issue in our work, because social workers work in typical organizations. They help people, they advise people, but we have a big other side. Social workers work there where the problems are developing. They work on the streets. They work in the last years, especially after the big amok issue in Winnenden in 2009. In schools, we have a very big we have a lot of people who are working as social workers in schools, nearly every school in our surrounding, and we have to take care of a lot of kids in our area, in our clinic. I have social workers. The idea after that is to be there where the kids are most of the time. Of course, we have no experiences with these terrible things in Israel, but we have experiences with the follows and with results of war in the world. In 2015, we have to cope from one day to the next one to work with kids from Syria and other countries which were walking alone, especially from Afghanistan, working alone weeks and months, and were traumatized on the way to Germany and traumatized in their countries. And we have to help them with all our experiences, but we didn't spoke Farsi, or we didn't spoke Arabic languages, and we have to help them very basically. And that is the way where the social workers can do things to help, to take care. And we have another big thing. I have only 5 minutes, so I have to speak a little bit faster. We have another very big thing that is such an emergency welfare system, where people they work maybe at the fire, they work at the police, they work for it's people from, they work in Ehrenamt. I don't know the English word. Thanks. And they go there where the problems are beginning. And the most important thing is that we have always to put the people in the center of everything. Of course, there are different reasons why people are traumatized, but at the end, you have severely traumatized people because of a lot of reasons, and you have to organize it very fast there what it happens in the beginning. And the highly developed trauma therapy or psychotherapy comes a lot of time later. First of you have to give security, you have to take care of normal things where you can. I work with kids, yeah, where can you put the kids that they are feel severe, which other people can help. And you need a big thing of solidarity, and social working means put all these things together, and you have to bring it to a continuum to us, the psychiatrists or psychotherapists. We supervise those people, we help with our experience. And we really started in 2015, for instance, or even after the last war in Ukraine, on nothing with our experience. And we had to develop in a very fast time structures and helping systems who could deal with those terrible things. Of course, there is a lot of other stuff to say. I hope I can answer some questions in the workshop, and that is my view as a child psychiatrist on those social working things, and from a very practical way. Thank you very much.
Thank you. And for now, any questions?
Yeah, I have a question.
Okay.
One of the things that I'm most curious about learning from the German experience is how you are able to take the situations where the care setting is not the hospital, social work, welfare, and integrate that into the larger system. Here in Israel, because of the situation, a lot of the initial touch points for mental health happen with welfare or social services, and that creates kind of a knowledge and information gap with the rest of the system. So I'm wondering how you're able to overcome this in Germany and get that world connected to this world.
I try to give you a good answer. Most of the time, our work uses corporations. We have, even as an outstanding clinic, we have tons of corporations with welfare systems, with schools, with boards, a youth board, and we always try to bring that stuff together, our knowledge. But the biggest thing is that psychiatrists and therapists have to listen what other people are doing, the social worker on the street, in the school, and we take their experiences and put it into our work. And so we don't work on a higher level in such a bubble of therapy. We try to put our experience into that, what kids in my way, children and adolescents and their families need. And that means to stay on the ground. You have to see what you can do in the first time, and you have to put it together, and you have to speak together and cooperate, and you have to bring your knowledge into the social work and the way back. Yeah.
I'm wondering more about how the data and information flows as well. Like if you're seeing someone a child somewhere in one region, and that touch point is social work or welfare, how does the information that this child had an interaction with a mental health professional pass through to the broader healthcare system, to insurance, to etc.?
Yeah, first of all, you as a doctor, as a therapist, you have to be silent. Yeah, you have. I don't know the English word Schweigepflicht. Lea, can somebody help me?
Sorry, it's the privacy that you have to sign. So
Yeah.
actually, you're not allowed to pass on the information about your patient.
But you ask, first of all, first day you ask your patient or your kid, the kid to come. So is it allowed that I can give important information to the people you take care of you? And is it okay for you that those people give me the information? And that is always every children, every adolescent says, of course, because they want help in those special ways. And then you have two things. The children continue to trust you because you don't speak about them without asking them. And on the other side, you get all the information you have to get for. And because we work together, and for instance, something in school happens, a kid is totally aggressive and says, I want to kill everybody. Yeah. Then the social worker there comes to the kid, takes care and bring it to us. And we have to take care together. What shall we do with the kid? Yeah. And so you can break it down till you get all the information and you can do the best thing for the kid. I think that is the, how can I say, that is a lower way to work together. It's not such privileged thing in therapy. It's working there where the problems are happening, and work together, everybody in his or her profession.
Thank you very much for all the impulses. I think, Yael, maybe in order to answer the question also with regard to data exchange and the continuum of care, we can open it up and see if we have people also in this workshop in the audience who have experience with the data exchange. Maybe Malek or maybe also Maria, you had some experience with that as well, working in hospitals or working as therapists. So let's just start the workshop now. And Yael.
Yeah.
If we stay at this topic, I could, this situation in Germany is highly fragmented. So there are large efforts which are being made to get the health data integrated. So even within the German health system, we do not have a unified data room. Yeah, as in comparison, for example, to the colleagues in Ukraine. And if you now extend it to the data space between social workers on the ground and healthcare facilities, there's no integrated space. So there are solutions needed, but they're not available currently in an extent in Germany how it should be.
Thank you very much. Maria, maybe do you have some graphs, do you have some numbers on also the experience of social workers, or what is your experience with that? Because I think what we're trying to find out also, Yoav is interested about and told us before the workshop, is the role of the social workers in Israel and how to incorporate it into the system, because as mentioned before, it's really also the beginning of setting up this mental health care system in Israel.
I can only contribute from my experiences from this psychosocial center I work with. And here we have an integrated approach where every patient, and the patients are refugees, experienced torture or war. And we have an integrated approach where every patient has a psychotherapist, a psychiatrist, and a social worker. So it's like a combination of all professions working together, and then the treatment is mainly based on the specific needs. So sometimes it's more social work, and sometimes it's more psychiatry or psychotherapy. And in terms of what the patient is needed, the treatment is like adjusted to the special needs. And so we have like this multi-professional team. And yeah, in terms of data protection, as it is already said, that we have like this sheet, and then you have to, as it is already described, give your allowance that you can talk to other doctors or share information within the center. So with us, it's a really important topic to have social workers to work with them, also adults, but also adolescents.
Within the framework or within one organization, so you can actually exchange. Yeah,
exactly. But nevertheless, the coverage of the costs is difficult. So we have a lot of donations, which allows us to have this multi-professional team, because it's not always possible to have like this multi-professional team if you're not really in the healthcare system. And especially for refugees, it is difficult.
Thank you. Yeah, and maybe you want to take over and see if we have specific topics or questions. We can also offer to open breakout rooms or just facilitate further conversations after this talk. But yeah, I'll pass over to
Yeah,
you.
sure. So I think that there's still some room for more broad questions and not just specific deep dives. For I guess for specific deep dives, I suggest that, you know, you can reach to us and we can connect to the relevant ones, relevant participants, because there are a lot to learn. And for each and every slide of Malek, for instance, I had tons of questions, as well as Maria. So I think one of the questions were regarding Shawan. Do you want to maybe to ask a question?
Hi everyone, my name is Shawan, and I'm from the Directorate of Government Medical Centers, which is actually the sort of the headquarters for the government-owned medical hospitals in Israel. Among them, 8 mental health hospitals, and my job title is innovation, so I'm obviously participating in discussions like these. But every time I'm struggling to understand the part, or what is the role of the hospitals themselves in this reorganization, redoing things, innovation, transformation, because it feels like the main impact or the main transformation should occur in the process, in how to identify, how to stratify, how to triage, how to offer services that are not huge, but when it comes down to services that a hospital provides, then it's the same. So I'm trying to understand what we can do differently, or what kind of transformation we can hospitals can take as a role for themselves in a situation like this. And I don't have an answer there.
John, is this specifically for mental health hospitals when you address that as like smaller, more specialized ones?
No, I think it's a general, and it's not even a question. I'm not inventing a question. It's you have a system. The system has the payers, and has in Israel that you have the HMOs, and you have the Ministry of Health, and so in every such situation, every different player as their role. And it's always, and the hospitals are allegedly are the ones providing care in acute situations or chronic, very chronic situations, and they're not the national, we don't have the national view of things. We're not in charge of the whole process. We don't decide which patient needs this type of care or the other type of care, because that's the role of the HMOs. So every time and now it's more focused on mental health. That's the situation we're talking about. So we can either answer the question regarding mental health, or we can have more general answer. Doesn't matter.
So I think, and if we can define by that, it's like when you talk about a hospital where there's specific range of services, when you look at it on a specific setting, how would you, like maybe Malik, I know it's different, right? It's not a specialized, only a specialist specific hospital, but how do you manage that? Looking specifically for in a hospital setting when you see only part of it and still engaging and massively with the patients.
Yeah. I think that the most important thing there is that we really need to take a bird's eye view, and we all tend to think within our silos. So an ideal world in the future would be a hospital which does not provide treatments, a hospital which rather provides preventions, a hospital who says, well, this is not my job to do so. I'm going to delegate this to social workers. I'm going to delegate this maybe to lay counselors. Yeah, and by that we can help much more people. So I would see the role of it can be a hospital, but it could be somewhere else. But a potential role of a hospital, at least an academic hospital, would be to develop a framework where much of the treatments and much of the interventions, including preventive interventions, are not provided by hospitals, so that within the hospitals only those persons receive treatment which are really in need for treatment. Yeah, I don't know whether that answers the question, but it is, I think, very close to, maybe Ran can add to that, very close to that what Ran is currently developing. Yeah, so it is, we're not talking about a doctor who provides treatment. Yeah, so we are talking about increasing capacities massively, and there's an urgent need everywhere, and the digital tools play a crucial role. Yeah, digital interventions which are provided cannot provide it to those who are severely ill, but to those who have maybe a low level of stress, low trauma load.
So what you're saying is, in a way, me being a hospital, I don't need to do anything now. Everybody's working around the clock to find solutions to everyone else, and I'm still just treating the very ill patients. That's what I'm trying to understand every time I attend such a webinar. What should we do differently? The hospitals.
Yeah. So maybe if I can directly answer what those are experiences from different settings, different locations in the world, including in Berlin, when we had this high increase. It was one of the first things which we did. We developed clearing clinics where we did a very fast assessment of load and a triage system, so that we changed the system to somebody appears, he receives treatment, to rather 10 people appear, and then we look out of these 10, who's the one who urgently needs the intervention. Yeah, and this is something which we immediately did within the hospital, and that might be the first step.
Okay.
But I think Malik, right, maybe Ran, you could also elaborate on that, because as he said, we're supposed to see it with all stakeholders involved and from a bird's eye. So maybe you have this point of view.
I think that it's good to borrow some examples from care that is not in mental health, where in many countries, what we in Israel do in a general practice clinic, they do in hospitals. And we have shown over the years that much of the work that's being done in hospitals for physical care can actually be done very well within a GP clinic. And much of the work that is done in a GP clinic can be done very well with digital tools in various ways that reduce the burden on the healthcare system and increase the effectiveness of what you do. So basically this whole thing of the skilling and basically trying to make sure that every level of risk and needs receives just the amount and just the type of care that they need and not more is not only helpful in maintaining a sustainable system, but also in not over medicalizing and over treating cases that do not necessarily need that level of care. But this exact fit and finding out which one should be taken to which tier of care is an art, which we have through the last decade and a half tried to master in physical health. And we are now making our first baby steps in doing that in mental health. But I strongly believe in this approach of tiered care, as well as in pushing the needle from response to prevention to proactive care to an early intervention as you can, which then allows you to use less skilled individuals to provide better care, which is preventive rather than coming late. And then you actually need, a much more advanced facility, a hospital, etc. It's easier said than done. We do have some experience, again, with physical health, and we need now to develop this as we go. The problem is we need to basically tie our shoelaces while running. We have an event on hand and we need to reinvent and reshape and restructure the system while it is collapsing on demand. So this is a good, interesting challenge that we are facing right now. And we're doing our best to try to tackle it.
Thank you very much, Ran. Maybe we have a question in the chat by Rani Cohen from Grey Matters. And I think in order to get into one of the practical examples of what internet-based applications can actually do and already do, Rani could introduce us to Grey Matters, and maybe Maria, you can respond to that as well. Rani, are
Yes,
you?
can you hear me?
Yeah.
Hi. Thank you for this conference. We are finding our solution as a kind of digital, but not exactly. And one of the questions that first I want to ask all those that deal with interventions from the internet, and I'm not talking about telehealth and psychiatric sessions in the internet, but digital helps for mental health. The findings right now is 95% of them, after 2 weeks, the patient doesn't use them. So it's not, the compliance is very low. So how do you think this can be changed? And the other things, it's I do, if it's okay, give you 2 minutes about the solution that we have, which is not theoretical, which about 4 months ago got FDA approval to treat PTSD. And you may not know, but this the only PTSD solution worldwide that got approval from FDA in the last 2 years, because not a lot of people are coming up with solutions to PTSD. And what we did was not to wait, and through donors and some of the hospitals that we worked with in Israel, we already have 3 systems working in Sheba, Ma'ale Carmel, and Barzilai, and 4 hospitals are coming up. And we have a digital solution in the sense that there is no intervention from radiation or drugs. We use neurofeedback. but we are the first system that can pinpoint EEG to a biomarker of the amygdala, which is the major area that is hyperactive in PTSD. And we have a set of 15 sessions, twice a week, half an hour. And the results that we received are better than the CBT treatments or drugs that connected to Germany. We're now in Mannheim, Mainz, Gießen, Charité Berlin, Tübingen,
Okay, so
and Hamburg.
sorry, Rani, your internet connection is breaking up a little bit, which makes it
Doing a very large trial.
it makes it a bit hard to understand you at the moment.
Okay.
But if anyone has questions afterwards about
I said that we are now in Germany,
yeah.
also in Mannheim, Mainz, Gießen, Charité Berlin, Tübingen, and Hamburg, also giving PTSD treatment in Germany. So if anybody wants to know more, or in Israel, in the hospitals and so on, they can connect with us. And if anybody has questions here, I'd like to answer.
Thank you. And again, as I just wrote down in the chat, let's just open up this round and pretend we're sitting around a table and having a conversation. So if maybe Maria Böttcher, also Lars Hunzel from the Ministry of Health, talking about digital health applications, would like to, well, maybe add some more information, but also if you have some specific projects in mind already, or some shared corporations that you'd like to propose here, or you just have an idea or whatever, let's brainstorm a little bit. Just speak.
Maria, would you like to go first?
Yeah, thank you. Yeah, thanks for introducing gray matters. I will have a look on that. And congratulations to the FDA approval. And you're totally right when it comes to like self-guided interventions, then the dropout rate is really high. And you can see that after like a couple of days or weeks, they stop to work on that. And I think that is maybe a challenge to create apps when they are self-guided, which are so attractive and motivational that the participant keeps track on that. And we were thinking about using AI to get into a dialogue, although there's no human behind it, to have like these guidance, although it is an AI guidance. But if you look at internet-based treatments which are guided, you see that the more guidance you have, the less dropout you have. So there is like a correlation between the dropout and the amount of guidance. So I think the main challenge will be how to attract the online interventions when they're not guided. Yeah, first thought about that.
Probably two thoughts. One to supplement what you were actually saying, and another one to I think what Ran was referring to. I think first of all, it's quite interesting to see we already covered that we've got certain types of interventions, whether it's telemedicine, whether it's digital only, whether it's blended care, and what the interesting question is how you actually try to integrate them in the system and try to create patient journeys that actually help to somewhat leverage pressure or take pressure away from the system. And what we've seen, and that is probably just the first step with DIGA when it comes to anxiety and depression, it's mainly the general practitioner. It's not necessarily the specialized psychotherapist, but you need someone who's the go-to guy. That can be someone in self-help who's qualified. This can be someone who's a medical general, who's the family doctor, who's the first practitioner. Could also be a health insurance fund, depending on the structure of the health insurance. But there is someone who needs to guide someone to say, well, for you, try it with the digital application first, and there is the mixed approach between technology and intervention, and then there is probably the qualified hospital or the outpatient whatsoever psychotherapist. I think it's quite complicated, and it's quite complicated to find someone who is the guide in the system and who's actually doing that kind of triage, if you want to put it like that, or what you want to call it. I think that's a quite important question. Who's the first person who has contact with someone who is in need of care, who is in need of help, and who can guide a person in the direct structure? That is one important point. And what I would like to echo is what we are seeing with the digital health applications. At the moment we have very poor data on compliance, and we expect that to be better in a couple of years only. We're just introducing measures to assess that on a regular basis and to create transparency concerning actual applications that got approved for reimbursement. But what I would like to echo and what we are seeing is that we've got these applications, and what actual health insurance funds are doing. They are trying to add extra services to the technology. So you mentioned coaches, you mentioned experts, psychotherapists that somewhat are included in the application at a certain point, at a portion where the patient, or where it feels like, well, the patient is leaving an application or doesn't continue to use it. There is someone who is actually asking, why are you doing that? Or who is offering help, or who might guide someone to use to get another form of treatment. And that's what we are seeing, what is happening at the moment. So it's always good to have someone at the very beginning to say, well, you could try it with an application, but also when you're using a digital intervention, there's always good if this application is designed in a way that it has certain, let's say certain milestones or certain somehow evaluates, well, the patient uses it and there is someone to guide someone. So digital only is something which can be a solution, but it's also something which has its limitations, and we're certainly seeing that. That said, of course, you mentioned examples. We have this list of DIGAs which are suitable for reimbursement. We've got some DIGAs that have, I guess, rather good evidence from what I'm hearing. RCTs that says, well, compared to non-treatment, it's certainly better. There is a list at the Federal Institute for Drugs and Medical Devices, comprehensive information, some in English, quite interesting, and I can provide the access there. Unfortunately, I cannot highlight, due to the fact that I speak for a government entity, I cannot highlight individual products here, but I can tell you where the information actually lies.
But there actually is an event next week that will highlight some of the applications, right, Asaf? You want to say maybe a few words about it?
Yes, thank you. Thanks to the German government, the Minister of German, Lars was part of the idea and the knowledge that the German government shared with us about the DIGA scheme was very important for us. We invited several German health tech companies in order to reveal the knowledge and the activity at the field of DIGA. And actually, we decided to design a tool in Israel. It's designing this right now in order to enhance the use of digital technologies in Israel. So first, I want to thank Lars and Thomas and Tobias and Susan that they helped us a lot to learn the DIGA scheme, and we're supposed to have at the 18th of December an event that reveals some of the startups that are working already now with DIGA. So thank you.
And here is always the issue of really if there are some of them that are in English already, but what it takes to have them have it usability in Hebrew, either from German to Hebrew or from English to Hebrew. I think for that also it's in terms of capacity of the organizations themselves to do that. And we hope that it would not be as like a barrier, a massive one, that it is feasible. Lea, do we have time for one more question, or?
We just decided we will extend this a little bit because, as I said, it's a kickoff, but still we already have some very concrete questions. And your colleague from Health.IL just texted me. Serious DIGA questions. Can you post them?
So this is my question. DIGA, I think, is a very interesting platform to effectively create a situation where you're proliferating the use of digital tools by guaranteeing reimbursement for them. And I'm very curious about this with regards to mental health in Israel, because one of the big challenges is that reimbursement pathway, right? How do you take these tools? And, I personally have mapped out every single one in Israel. And the big question is always about this reimbursement. So my question, Lars, I'm going to go back to you on this, is has DIGA have you seen it assist in getting these digital mental health tools in use in the population?
Well, first of all, one has to say DIGA is a pathway. It's been a start, and it's something which is proceeding gradually and step by step. So what we did was we started small. In terms of risk classes, medical devices risk classes 1 and 2A has its limitations. Technology only, or a strong focus on technology only, has certain limitations. What we are seeing is it's not the big bang, not necessarily only related to mental health. We're seeing that mental health is certainly the field where we've seen most applications, and probably we'll have new data by the end of next year. It's a pity that the last report of prescription numbers is already 1 year old. This will change probably at the beginning of next year. We'll have quarterly dates then. I would say yes, and I think that it's a process that is accelerating. We're seeing that the number of prescriptions is going up, and we're seeing that the number of doctors who are prescribing DIGAs is going up. However, what is certainly needed is that manufacturers, it's not only that we're having a list and saying there are quality applications, you can either claim them with your HMO, or you can get them by prescription by a doctor. You also need to convince those who citizens actually turn to. You need to talk to manufacturers. Need to talk to doctor. You need to make sure that you're in medical guidelines, and that DIGAs become parts of medical guidelines, in order to make sure that they are that receiving a DIGA is the adequate or the standard of treatment in that medical field. And that is complex, and that is what somewhat is slowing down the process of integration. But what we are seeing is, yes, there is an uptake. The number of prescriptions is increasing. The number of there is a tendency to say, well, it's listed, it's been approved by the Federal Institutes for Drugs and Medical Devices. It's a good one to some extent. There is certain criticism, but that rather refers to those that have not yet produced evidence. But in terms of those who are listed permanently, I think we're on a process. It's not a big bang, I guess.
This just adds more questions, but I may email you separately.
It does. It does add questions. Certainly add questions, and we are unfortunately not in the best position to answer them, because we just received in the last 2 years we just received yearly reports on prescriptions, and I've already mentioned there's a bill in Parliament which will pass Parliament next year, and then we will have quarterly reports, and we will have certainly better and more detailed number on what is going on out there. Yeah, I think we're in 2 years to be honest. Or started in October 2023, so 3 years. We're still in the process of evaluating and of learning, I guess.
It's good we have more questions. I think this is a sign that we have to keep on cooperating and talking to each other. So again, just for everyone who's in the call still, if you also have further questions to some of the speakers we had, or also participants here, we are very happy to facilitate and continue this discussion, maybe also in smaller meetings. Yeah, and maybe you have some more questions or would like to invite people also from your community, because I guess, yeah.
Yes. So I am not the person that will ask personal, like people just to ask questions, but I think that one of the issues here, and it's something that I don't think that we only here to learn from each other. That's it. I think that we can think of commonalities where we can collaborate. I know in different discussions we were talking about how we can leverage some work and research that has been done in other countries, and then to integrate it and help to, for instance, if it's an AI-based research that already been performed based on data in Germany, to do some work specifically on the elaborated data that would occur from Israel from the next 10 years, I would say. And so just to put it here, if you're interested in performing some collaboration, and it is for both Israel and German audience, we'll be happy to mitigate it and help it, work out. So I think that's our note. And if anyone else has questions, Emmanuel, or I don't know, because you're unmuted.
Emmanuel is going to sum up a little bit.
Okay.
This is why he's unmuted.
So should I sum up now, or are there more questions?
Yes, please.
Okay, sorry. So good afternoon, good evening to everyone. So yes, I would like to conclude this very informative and productive event, which is a reminder of the fact that mental health has become a central issue and challenge for health services in Europe and in Israel. Of course, it became obvious with the COVID crisis, but even more so with the war in Ukraine, and now with the war against Hamas in Israel. And I think it's a reminder that Western democracies are not immune from these shocks, and therefore must learn from one another to better handle the health needs of their citizens, which is exactly what this seminar intended to do, and did very successfully, in my opinion. ELNET looks forward to continuing its cooperation with GIHF-AI to increase scientific cooperation between Israel and Germany. This cooperation will hopefully produce a GIHF-AI conference in Israel in 2024. And I would also like to thank the health ministries of both Germany and Israel, as well as Health IL, for organizing this event, as well as the teams of ELNET Germany and of ELNET Israel. On a more personal note, I would add that, of course, we in Israel are facing pressing mental health issues because of the war, including the emotional pain of losing family members and friends at the front, and of course that of having loved ones held hostage by Hamas. But as the holiday of Hanukkah teaches us, light can prevail over darkness, and that light also includes knowledge and scientific research. So I'm very glad that we had this seminar, and I look forward for this seminar to produce more cooperation and research between our countries. So thank you all, danke schön, and for those who celebrate Hanukkah, Hanukkah Sameach.